Good morning, everybody. Since this is a first meet after Holi, so let me first wish you all a very, very happy Holi. Sir, पीछे तो कोई color नहीं लाया हो. I'm worried. So I think as long as there's no color, it's fine. So we started surgical gastroenterology department at Mahatma Gandhi Medical University in 2013, and presently I am the luckiest one because I have my teacher and my student with me in the same department. Dr. Kapoor sir has been my teacher since SGPGI, and Vinay has been the student when I joined SGPGI, and he was the exiting batch. So I am luckiest person. And we started our MCH in 2020, and we have had, this is the second batch. The initial first two students, and now we have two students per year. The two batches have already cleared. What are our areas of interest? Actually, the thrust areas are laparoscopic and robotic, especially the GI malignancies. We do complex hepatopancreatic biliary surgeries and liver resections, and any complicated hernias or retroperitoneal tumors. That is our area of interest. We have a vast experience of gallbladder biliary surgeries with luminal surgeries, duodenal, pancreatic. We do a lot of PDs and abdominal surgeries, and we are the center which did the first robotic fundoplication in Rajasthan, and we did the first robotic bariatric surgery at our institute in Rajasthan. So, and we have a academic session on daily basis. On Monday we had it with it's an online class with Asian Institute of Gastroenterology, and Tuesday a case presentation, and Wednesday we have a common clinical rounds, and Saturday Jaipur surgical tutorial is again a online and offline class. We do a master class on a monthly basis, and we are having more than 100 students in the master class at present, and with the topic of core GI surgery being chosen every time. Let me tell, these are all Dr. Kapoor's ideas which have been generated by him, and we are followers. I think now we have more than 200 top followers by now for his ideas to be implemented. Jaipur Swasth Charcha is our area of core interest of not only academic, non-academic, general population. Our area of interest is definitely a bile duct injury, and we often get a WhatsApp consultation, a video consultation. We try to teach the peripheral surgeons who are in periphery, who don't have a vast exposure. They send us a video, WhatsApp, that this is what we have had on bile duct injury, while I was doing a lap chole, and then we try to help them out. Recently, today morning, yesterday at night, I got a call for a post lap chole. They were doing a lap chole, they had a burn on duodenum, and we are just admitted, and we will be taking that case in short while now. So we do a Jaipur Surgical Festival. This is the fourth Jaipur Surgical Festival that we had, and one of them was a part of IASGO PG course. Publications, we have now a wide exposure of number of publications from our all faculties as well as from the students contributing to it, and the recent publications have been on gallbladder cancer, bile ducts, and to emphasize specifically, last CCR, if somebody remembers or forgotten, I don't know, I told that we will, when we were doing a pancreatic Whipple's case presentation, I told we are planning to have these two publications, and both have been accepted and now in press now. So just want to emphasize that both the points have now been accepted and they will be about to get published, and I'm very thankful to my dear colleague Vinay, who has done a lot of hard work into it after all the work has been done by Dr. Kapoor and me, that he with Dr. Piyush, who was our consultant earlier, he's in AIIMS Jodhpur, they could get it to a final shape of getting published now. All of our residents have published, presented in national and international conferences. They have got very often best paper and the good paper awards. Now I request my colleague, my resident, my very bright student, Dr. Rajiv, to come and present on this case. The topic is management of recurrent jaundice in pregnancy after biliary surgery. So I think we will have a storming questions and answers. I expect that.
Again, a very good morning to everyone. The case I am presenting today is of a 25-year-old lady in her 5th month of pregnancy. She is a homemaker coming from Alwar, Rajasthan, belonging to a middle-class family. She presented to us with a complaint of jaundice and generalized itching for 3 months and recurrent history of fever for last 2 months. She was asymptomatic 3 months back when she noticed yellowish discoloration of eyes and high colored urine, which was insidious in onset, gradually progressed. which was insidious in onset, gradually progressive, without waxing and waning. It was also associated with itching, initially over the limbs, later became generalized, affecting her daily activities, and she was having disturbed sleep because of the itching. She had mild improvement in itching after taking the medicines she was prescribed at a local government hospital, but however, her symptoms of itching were persistent. She also gives history of fever for last 2 months, which were of high grade and associated with chills and rigors. It used to be initially once a month, and now she was having it every third to fourth day. Each episode of fever would last for almost 1 hour, and used to subside after taking medication, which were again provided at a government hospital in the local place. And last episode of her fever was 3 days prior to when she presented to us. There was no history of pain abdomen, no history of nausea or vomiting, no history of loose stools, no history of pale colored stools, no history of recent blood transfusion, no history of loss of appetite or loss of weight. Now, at this point, for academic purpose, I would like to, without revealing further history, I would like to ask the students and the audience, what are the causes of jaundice in pregnancy? Anyone else? Any medical causes?
यानी ये प्रेगनेंसी में जॉन्डिस के चांसेस इंक्रीज क्यों हो जाते हैं? Why the pregnancy is responsible for increase in bilirubin level than a normal non-pregnant female or a male? What those things are responsible? Name the basic thing. Yes, it is increased level of estrogen and progesterone also. What is the role of estrogen? ये हमेशा याद रखो बेटा कि एस्ट्रोजन कहीं भी जहाँ भी बॉडी में एनलार्जमेंट होगा, चाहे यूट्रस का हो, चाहे लीवर का हो, चाहे हार्ट का हो, किसी का हो, एनलार्जमेंट प्रोग्रेस चाहे ब्रेस्ट का हो, इज ऑलवेज बिकॉज ऑफ एस्ट्रोजन. प्रोजेस्टेरोन का काम होता है रिलैक्स करना, है? जैसे मूवमेंट्स इंटेस्टाइन के स्लो हो रहे हैं, वेजोडाइलेटेशन हो रहा है, किडनी का एनलार्जमेंट इज बिकॉज ऑफ एस्ट्रोजन. पर यूरिन में कोई प्रॉब्लम आ रही है, कॉन्स्टिपेशन हो रहा है, स्टूब यानी इंटेस्टाइनल मूवमेंट्स वगैरह कम हो रहा है, ये प्रोजेस्टेरोन की वजह से होता है. सो इट इज द इफेक्ट ऑफ ईस्ट्रोजन, बिकॉज ईस्ट्रोजन इज प्रोटेक्टिव हार्मोन फॉर द लीवर. बट इफ समथिंग गोज रॉन्ग एंड out of that, why some patients have jaundice only or itching only during pregnancy? Icterus gravidarum, ictra, क्या बोलते हैं उसको? Icterus gravidarum, है? Itching of the pregnancy, Icterus gravidarum, क्यों होती है वो भी jaundice से related है. बताओ दूसरे रेजिडेंट्स बोलो. कोलेस्टेसिस होती है, क्यों होती है? कोलेस्टेसिस होगी तो जॉन्डिस होगी. बाइल एसिड का नाम सुना है? क्या होता है बाइल एसिड? Yes, it helps in the emulsification, but in pregnancy it deposits more, all right, dysregulation, and that is the cause for itching. Bile acid, not the bile pigments, all right, remember this.
So causes of jaundice in pregnancy can be grouped into 3 categories. First include those specific to pregnancy and which either resolve spontaneously or with the treatment or following delivery or termination, which include intrahepatic cholestasis of pregnancy, severe eclampsia, HELP syndrome, acute
Can be HELP syndrome, define full form.
So hemolysis, elevated liver enzymes and low platelets.
In which condition it is common? Last seminar was there on this one.
Sir, in third trimester of pregnancy with eclampsia and pre-eclampsia patient having hypertension. Yes. Then acute fatty liver of pregnancy, severe hyperemesis gravidarum can also present like this. Second category.
What is the difference in severe hyperemesis gravidarum and HELLP syndrome?
Sir,
Which duration of the pregnancy both things will happen?
Sir, severe hyperemesis gravidarum is usually in the early trimester of pregnancy, in first trimester, and towards third trimester is HELLP.
This is the important difference which all of the gynecologist, obstetrician and maybe physician should know, that HELLP syndrome is in the later part of pregnancy, while the hyperemesis or excessive vomiting or nausea is in the first trimester or second trimester of pregnancy.
The second category involves jaundice unrelated to pregnancy, but which are mere coincident during the state of pregnancy, which include viral hepatitis, gallstone related obstructive jaundice, drug induced jaundice, and hemolytic jaundice. And third category includes those diseases that cause jaundice which predate to the pregnancy, which are chronic hepatitis, cirrhosis or tumors, autoimmune hepatitis, or any prior hepatobiliary surgical intervention. These are the salient features of few of the conditions, namely hyperemesis gravidarum, which has early onset as we discussed, and intrahepatic cholestasis of pregnancy, which is one of the only with the causing pruritus and cholestasis.
Pruritus is because of
bile acid accumulation. It is because of the dysfunction of bile acid export pathway, and acute fatty liver of pregnancy and HELLP syndrome are usually seen in late trimester. Viral hepatitis and autoimmune can occur at any place of any duration of pregnancy. Since this patient had a significant past history, I would invite Dr. Vinay Kumar sir, Associate Professor from our department, to explain regarding.
A very good morning to all. Now in further few slides I am going to explain about the etiology. So the patient having past history of pain abdomen since last 3 months without jaundice, 9 months back to a hospital elsewhere, and she underwent MRCP which was suggestive of choledochal cyst type 4A. So what exactly is the choledochal cyst? So first we have to understand what is the choledochal cyst. So choledochal cyst is a congenital dilatation or cystic malformation of the bile duct, which can involve the extrahepatic as well as both. There are many theories why it exactly happened to the patient. One of them is that just because of the abnormalities in the pancreatico-biliary junction leading to the bile reflux, ductal wall weakness and progressive dilatation. So there is a further classification of this choledochal cyst, that is Todani's classification, and this choledochal cyst is more common in Asian countries, like we are in Asian countries. So the incidence of choledochal cyst in Asian countries are 1 among 1000 to 1 in 5000 live births. So and in Indian data it is approximately 1 in 10,000 live births, and in while in Western countries it is approximately 1 in 1 lakh or 1 in 1,50,000 live births. Familial cases are there also in the data for less than 10% of all the choledochal cysts, so reported in the siblings also. So the Todani is the first one who has classified this choledochal cyst depending upon the involvement of the intra as well as extrahepatic ductal system, and the classification broadly classified this choledochal cyst in 5 types: type 1, type 2, type 3, type 4A, type 4B and type 5. This is basically according to the involvement, like type 1A is the solitary involvement of the only extrahepatic cyst, type 2 is extrahepatic diverticula or the secular dilatation of the biliary extrahepatic bile duct, type 3 is the choledococele, that is the basically the at the level of the sphincter of Oddi, and type 4A and 4B is depending upon the involvement of the intra or the extra or the both, like 4A is the only extrahepatic involvement, 4B is the both extra and intrahepatic involvement, and 5 is further, that is the advanced stage, that is involving the intrahepatic, further also named as the Caroli's disease. So what our patient has is And the treatment basically depends upon the type of the colorectal cyst. Like type 1, the treatment, the surgery guideline is different, type 2 is different, type 3 and type 4 is different. So type 4A, and the gold standard treatment for the colorectal cyst is the surgical excision of the cyst with biliary reconstruction in form of Roux-en-Y hepaticojejunostomy for prevention of the complications. So my question for all the audience is, what exactly is the treatment for asymptomatic colorectal cyst diagnosed incidentally? If someone has underwent USG and that is suggestive of colorectal cyst, what will be the treatment modality offered to the patient? Any of our surgical fellow? Yes.
Sir, according to old data, we used to leave it and we did not need any treatment if it is asymptomatic. But recently, in past few years, we have seen that even if it is asymptomatic and incidentally diagnosed, then we have to do some procedure, surgical procedure to correct this disease. So we can do hepaticojejunostomy or hepaticoduodenostomy or other resection anastomosis procedures depending on the site of the cyst.
Rightly said, very well. Because
वैसे जनरल प्रिंसिपल पूरी मेडिसिन साइंस में ये है कि अगर कोई चीज़ एसिम्प्टोमेटिक है तो उसको छेड़ो मत, कहीं भी, इम्पोर्टेंट चीज़ है, अनलेस इट
apply to many conditions.
I beg your pardon, sir, but previous data are in support of the colorectal cyst also, but with advancement, when data has accumulated and they found that the lots of incidents of complications associated with the colorectal cysts are there, like in the form of bile stasis, cholangitis, stone formation, as well as the malignancy.
You will find so many problems with the patients
Sir,
later on.
it is a pre-malignant sort of condition. Malignancy risk is there with prolonged duration of the disease. So, if a colorectal cyst is diagnosed in a younger age group of patient, then definitely surgery is the treatment of choice. But if the patient having age of more than 70 years and incidentally diagnosed to a colorectal cyst, then the chances of malignant formation of this colorectal cyst is very less. Then we can leave it. Otherwise, in a younger patient, it is indicated right now and supported by the data also.
हमारे ज़माने में तो ये पढ़ते थे कि जब तक प्रॉब्लम नहीं हो, don't invite problem. चलो.
If the patient is fit, the patient is fit. Only contraindication is an unfit patient. So in one that unfit patient specifically comes for the elderly patients who are more than 70 years of age, because they are definitely frail patients, and doing a surgery in an asymptomatic in that group may have risk, but otherwise, even if it is diagnosed in a child who is 3 months old, the indication is that. So
actually, sir, data is stating that every 10 years, the chances of risk of the malignant formation of the colorectal cyst increases with 2%, then 4%, then 16%. So if patient is harboring this colorectal cyst last 30 years, then the risk of malignant transformation is approximately 18 to 25%. That's why we used to advise the patient in younger age group for to opt for the surgery. So the what exactly our patient has been offered? Patient underwent laparoscopic assisted colorectal cyst excision with open Roux-en-Y hepaticojejunostomy, and details of the procedures were not available. So it's a brief video presentation. I would like to show how this surgery used to be do for the colorectal cyst excision. This is the video diagram. The excision of the extrahepatic biliary system involving the colorectal cyst. Then taking a loop, Roux loop of the small bowel starting from the DJ 20 centimeter. Then directly anastomosis to the biliary system, and side to side jejunostomy has been done approximately 40 centimeter of a Roux limb. That is the classical description of the Roux-en-Y hepaticojejunostomy. There are lots of methods of doing this hepaticojejunostomy, like some people used to do with interrupted manner, some people used to do in continuous manner. My Ajay sir will further tell you about one of our students is doing a study on interrupted versus continuous manner, because in our department we are doing continuous manner, but in most of the departments or most of the centers in India they are doing in interrupted manner. So that's why we have given the study to our student, and our results are far better than interrupted, sir, and the cost cutting is there, and already that data has been published in SGPGI with more than 500 patients, and they have compared both effectiveness, stricture formation, cost cutting, because in in interrupted manner, lots of sutures of that PDS 50 or 60 is used.
Traditionally, it was being done by a interrupted suture. That is how we have been trained in last almost 25 years. We have changed this 10 years back when the first data came, and then subsequently there have been a lot of support from the data from West as well as from the country to do it continuous suture. Continuous has come specifically after starting of laparoscopic surgery. So in laparoscopic, continuous became easier. So after that they found that there is no increased incidence of stricture rate. There is a equal incidence of stricture in either the two. There is a equal recovery rate, but the time taken is less, anesthesia duration is less. So the entire trend has changed, is now changing towards a continuous suture now.
नहीं, मैं एक जनरल प्रिंसिपल की बात कर रहा हूँ. जो बेसिक एनाटॉमी का प्रिंसिपल है, जस्ट देयर शुड बी सॉर्ट ऑफ पोजीशन ऑफ द टू लेयर. Problem comes whether you are using continuous suture or you are using interrupted sutures, or you are using another type of the suture, mattress sort of sutures. How much force you apply?
Absolutely.
It is from surgeon to surgeon that varies.
Yes, sir.
Because we do tuboplasty. I have done a lot of vasotomies. Reconstruction of the vas and epididymis. The diameters बहुत ज़्यादा difference होता है. 16 time difference होता है epididymis में और vas में. It is the force. How much tension you are putting on these tissues, that makes the difference. Okay? Plus, of course, you should be well versed with the microsurgery. You should do under magnification. You should use absorbable suture. You should use 10 or 12 or that sort of sutures.
Very true, sir. Yes.
So I think it is more with the surgeon. This is what I feel. Maybe I may be wrong, but we are here for discussion. Maybe wrong, or but both should be all right.
So very true. So it's basically a matter of expertise, how you used to do, because the chances of stricture formation is definitely there with the continuous, because it is making it like a purse string. So how you used to do it, it depends on. So this is the only document we got from her prior admission. Here I would like to emphasize on the importance of a good and detailed discharge summary to our residents, because detailed summary would have helped us understanding and suspecting the possible causes, like what had happened to her intra-op findings and all those things. So because that intra-op finding will better tell us exactly what is the size of what was the size of anastomosis, what was the exactly level of the anastomosis, ductotomy was done or not, blood loss was there or not, type of the sutures, what the surgeon has used, and continuous or interrupted suturing. So all those details are very important if we are dealing with a referred case, because that is basically a base mark to plan for the further surgery for a referred case, already operated case. So post-operative stay was uneventful. As per her history, post-operative stay was uneventful. Drain was removed on post-op day 4, and histopathology was negative. Histopathology was suggestive of inflammatory changes in the CBD without any evidence of the malignancy, and chronic cholecystitis of GB with calculi, and she was discharged on post-op day 8. So to further continue, I would like to call Dr. Rajiv.
She did not have any known comorbidities. Obstetric and menstrual history, she came with a history of amenorrhea for 5 months. She is a primary gravida in 5th month of pregnancy. Previously she had normal menstrual cycles with 28 days cycle and 3 to 5 days of flow. Yes. Her last menstrual period was 17th of December 2023, and according to that her period of gestation was 23 weeks and 4 days. And coming to personal history, she is a vegetarian by diet. There was no history of bowel or bladder complaints, and family history was nothing contributory. And history of medication, she was on multivitamins and iron supplements as per her antenatal advice, no history of any alternate medication. And for the above mentioned complaint, she had consulted at a private government hospital at her local place after developing jaundice, and she was advised, and LFT, USG and MRCP was done. Liver function tests were showing raised direct and total bilirubin and raised alkaline phosphate with slight raise in transaminase. And ultrasonography which was done outside showed bilateral.
Just my suggestion, total और direct के बजाय आप conjugated and unconjugated बोलोगे ना?
Yes.
तो ज़्यादा better है.
Sure.
ठीक है? That will explain lot of pathologies also, symptoms also.
Then ultrasonography was suggestive of bilateral intrahepatic biliary radical dilatation. MRCP was told to be normal, but however they did not provide any films or CD, and even the report was just a handwritten report. At this point, to summarize the case based on the history, here is a 25-year-old primigravida in 5th month of pregnancy with history of laparoscopic assisted choledochal cyst excision with open Roux-en-Y hepaticogynostomy 9 months back, presenting with jaundice, pruritus for 3 months, and high-grade fever with chills and rigors for 2 months without any history of abdominal pain, vomiting or diarrhea or weight loss. So here I would like to ask the audience what are the possible causes in this patient after knowing the history that she had undergone a previous biliary surgery.
Symptoms पे जाओगे इसके लिए? और पीछे जाओ slide. नहीं symptoms. इसके stool का color कैसा है?
Sir, no, not pale colored stool, sir. In negative history we had asked.
ठीक.
So what are the possibilities in this case? Any audience would want to answer? So various causes of jaundice have been discussed in previous slide, but in this case with the history of previous choledochal cyst excision and Roux-en-Y hepaticogynostomy, more likely diagnosis would be hepaticogynostomy site stricture. Literature says 11% of incidence within 2 years after the surgery, and time to stricture formation ranging between around 3 to 19 months. The other possibilities can be hepatolithiasis, which have an incidence of 7% in cases of choledocholithiasis. Even though she is younger, since choledochal cyst is a pre-malignant condition, malignancy can also be expected, which has a literature incidence of around 11% without surgery and up to 4% even after the excision of the choledochal cyst. Coming to our general physical examination, the presence of icterus and scratch marks over the limbs were the only positive findings. Rest of the general physical examination was unremarkable and vital parameters were normal. And on per abdominal examination, she had visible bulge in the lower abdomen with linea nigra and striae gravidarum present. There were scars of previous surgery, mainly in right subcostal region. Right subcostal region. Sir, laparoscopic assisted surgery, sir. Anastomosis they had done open. Right subcostal scar, supraumbilical scar, and a scar at the drain side. On palpation, uterus was palpable just above the umbilicus, liver and spleen were not palpable, and rest of the abdominal examination was unremarkable. There was no evidence of free fluid and auscultation. Normal bowel sounds were heard. Fetal heart sounds were present, and details of which is explained later by the gynecologist, obstetrician, and systemic examination was essentially normal. So with the history after examination, to summarize the case, 25-year-old lady with primigravida in 5th month of pregnancy, an operated case of lap-assisted choledochal cyst excision 9 months back, presented with jaundice, pruritus, recurrent high-grade fever. On examination, had icterus and scratch marks over the body. Otherwise, clinical examination was unremarkable with findings consistent with her pregnancy. So with these, we went ahead with the investigation. In her blood investigation, it revealed increased total and direct bilirubin with elevated alkaline phosphatase, suggestive of obstructive jaundice. There was a mild elevation in transaminase, which can be due to the recent history of fever, suggesting cholangitis in this patient. With the high suspicion of obstructive jaundice in this patient who had undergone a previous surgery, we had planned for MRI. MRI abdomen and MRCP was already done 1 month prior, which was done outside, and she did not have proper films or CD of that thing, and just a handwritten report which was showing it to be inconclusive, which was not cooperating with her outside USG findings. So it was turned to be inconclusive. So we had requested for another repeat MRCP. But however, since the past MRCP, after that she had developed claustrophobia and fear for that investigation, and they refused for any MRCP. So without an ideal investigation in hand, we went ahead and requested our radiologist to do a USG abdomen with Doppler specifically to delineate the biliary anatomy and vascular anatomy of the in this patient, which showed central and left lobar IHBR dilation. It was dilated till the hilum. Hilum was formed. Distal CBD was not seen in this patient, and there were bowel loops at just below the distal anastomosis, and it was suggestive of anastomotic site stricture, and hepatic artery and portal veins were normal on Doppler. Here I would like any comment from Dr. Nikhil Bansal sir from intervention radiology.
Correlating with the as the patient is already had a history of operative, so this is correlating with the structures.
So with this investigation based on the history, examination and blood investigation and the radiological investigation, we concluded the diagnosis to be obstructive jaundice with recurrent cholangitis secondary to hepatico-jejunostomy site stricture.
So at this point in time, we had a diagnosis of possible stricture at the anastomotic site. We have a intrahepatic biliary radical dilatation, a common confluence of right and left duct from the liver, they being formed, and there is a stump beyond it. So with this, was it a medical cause? I think now we were pretty sure that this is not medical cause. So this is a surgical cause which we are seeing, or it can be treated by other measures, and we have a lot of our colleagues who can still fire us when we say that that is it endoscopic possible. This is a question mark. So maybe once I tell what was our opinion after our discussion with our medical gastroenterology colleague Sumit and Dr. Nijaman sir is here, who were Sumit has discussed, and recently we discussed with Dr. Nijaman sir also, that why taking a decision on the management by ERC was not possible, because normally ERC is done through the ampulla, and in this patient we had already had a ampulla. Beyond ampulla the CBD was divided, so there was a hepatico-jejunostomy beyond it, so it was not possible through the ampulla. It had to go through the rouleum, and access to the rouleum required a longer scope. Nowadays a lot of people do use a double balloon enteroscope and ERCP, and requires more time and risk involved, and specifically with the pregnant patient, was it wise? So we thought this is normally if you see that it requires, you have to go through the stomach, into the duodenum, into the rouleum, and then go into the hepatico-jejunostomy site. This has been shown in literature, it has been tried, but we felt that with this pregnancy, I think we were more wise that we should not attempt on that direction. Intervention radiology, Nikhil was there, and we asked his opinion. We were discussing, and what was the advantage? If we would have done an intervention procedure, we would have just put a tube through the liver into the biliary tree. One thing we could have done was draining it externally, that we just recover her jaundice. Second thing we could have done is placing the same tube across the anastomosis into the jejunal limb and making it as a stent. It can be just an internal stent, or could have been an external stent. Now, when we were discussing at this point in time with pregnancy,
how will you protect the fetus at 5 months or mid-trimester from the radiation exposure?
Yes,
any leads? What measures interventional radiologists will take?
Nikhil. Sir, in those procedures, sir, our preference of doing the PTPD is majorly an ultrasound guided only. We try to avoid the radiation, sir. In those cases where we can't, sir, we try to cover the lower abdominal part with the lead apron, sir.
We can have some comments from Dr. Nijaman sir also with his wide experience. Can we have mic to Dr. Nijaman sir with for endoscopic and intervention?
Yeah, actually we do a lot of ERCPs in pregnancy in CBD stone, and there we don't find any problem because we don't use fluoro, so we don't have to cover the fetus, and we do it just by having a selective cannulation and aspirating the bile in that cannula. So if we find the bile there, the best thing what we do is we push in a stent to tide over the crisis of pregnancy and cholangitis, and later on we deal with the stone.
So
And especially in this situation, it is a problem, as has been said by Sir also, that with such an altered anatomy, we require a fluoroscopy to reach to the hepatocogenostomy site. And we use either a pediatric colonoscope or an arthroscope, and side viewing doesn't work here because there is no papilla, so you don't do a side viewing endoscopy. So it's a front view scope, but it requires a lot of fluoroscopy assistance to reach that area, and it requires a lot of time also. It's not an easy procedure. So looking to the safety of the fetus and the mother, maybe we can avoid this, and interventional radiology simply by using an ultrasound and targeting the intrabiliary radicals and pushing in a PTBD is an option in this patient.
So for all the residents, I think the important message which has been given is ERCP is possible in pregnancy, but only and third only is with an experienced person who can do the endoscopic retrograde cholangiogram without a fluoroscopic assistance in a single go, with a less likelihood of complications, because a complication in pregnancy means a lot. You have two lives at stake. So I think this can be said by Dr. Nijavan sir, but I think youngsters, I think in beginning should avoid doing it, and with the experienced person, we are lucky. That's only I can say. We have such wide experienced people with us. So we thought that intervention radiological procedure was again not a very good option, so we decided for a surgery. Why did we decide for a surgery? That was a question now. Now, it was safe in second trimester we filled, and we have one of the largest experience in the country of hepatocogenostomies. This is from Dr. Kapoor in 1989 at SGPGI. They have been doing. I have joined in 2001, so I have 25 years, and he has additional 15 years. So we thought that yes, this is what we can do it better than other people.
The largest experience of hepatocogenostomy anywhere in the world. Unfortunately, because we have gallstone disease, we have a lot of bile duct injuries referred to SCPGI, and they need repair. So SCPGI has world's largest experience with Roux-en-Y hepatocogenosis.
So there's a difference between person like me who was playing on back foot and Tendulkar who hit six. So Sarra has directly hit that. No, actually we have wider. So I was at back foot. Yes, I had initially mentioned that we had a huge experience, and this is even at in two.
He's right. Now you are here, no? But why SGPGI?
So we are together.
It is not the place; it's the person which is important.
Actually, in UP, gallstone disease is much more common. And the setups where cholecystectomies are done, probably, this is my subjective impression, more bile duct injuries, and SGPGI being the only referral center, here a lot of patients would go to Delhi, a lot of patients may go to PGI, Chandigarh, so referral also is not, and then there is SMS and other hospitals, so there was a concentration of these cases at SGPGI.
I will deny Dr. Kapoor's statement now. We have had many calls in last few years from residents who want to join Mahatma Gandhi Medical College in Surgical Gastroenterology, and most of those senior surgeons all over the country with slogan that yes, underline that we have a mini SGPGI at Mahatma Gandhi. So we would like to our students to join at Mahatma Gandhi. So with all that, I think then we had a very high success rate which has been reported in the world literature. So we thought that single stop solution, matlab one solution at one go would be surgery. Decision taking, definitely thankful to Sumit over there, who was actively at that time involved in this patient. Nikhil did a lot of brainstorming for us, and we were defending, and our residents, and of course Dr. Jaya, who was helpful, Dr. Vijaya ma'am, who was very helpful, that yes, we will do this and we will be able to manage that. And so decision taking was for a surgery, a single steps treatment, avoiding the risk to pregnancy. USG and lab reports were strongly supporting a stricture. Previous surgery anastomosis was below the hilum, which was supporting us for surgery, and with a high likelihood of success, we planned for a surgery. So now we ask our obstetrician to come on the stage. Shreya is coming before the fire of questions. I think let Shreya take up the position, because we'll have a lot of questions beyond it now.
Good morning, everyone. I, Dr. Shreya, Junior Resident 2 from Obstetrics and Gynecology, will be presenting my case of 25-year-old Hindu female under the guidance of Dr. Jaya Chaudhary ma'am. So, Mrs. X, 25-year-old Hindu female, primary gravida amenorrhea of 5 months, referred from Surgical Gastroenterology department for preoperative antenatal checkup and fitness. Her last menstrual period was 7th of December 2023. Expected date of delivery was 14th of September 2024, and period of gestation was 23 months and 4 weeks. She had no past. Her past menstrual history was normal. No significant medical history. She had undergone choledochal cyst excision with Roux-en-Y hepatico-jejunectomy 9 months back. Patient was vitally stable. Icterus was present. Systemic examination was within normal limit. On per abdominal examination, uterus was around 24 weeks size. Her symphyzofundal height was around 22 centimeter. Relaxed. External ballotment was present. Fetal heart sound was present and regular, which was heard on Doppler. Preoperatively, we gave her injection hydroxyprogesterone caproate 500 mg IM, injection isosuprin hydrochloride 10 mg IM. Post-operatively, we gave her injection natural.
Mention that is for protection. Both progesterone also relaxes the uterus.
Relaxes the uterus
and isoxazoline.
Is it tocolytic?
बताओ ये.
Okay.
Dilators.
Okay, sir. Post-operatively, injection natural micronized progesterone 100 mg IM 12 hourly for 3 days, and injection isosuprin hydrochloride 10 mg IM 12 hourly for 3 days. Post-operatively, we regularly check her fetal heart sound, and USG sonography fetal well-being was done, which was documented as single live fetus of 23 months and 3 weeks. Amniotic fluid index was adequate. Placenta was posterior grade 2. Estimated fetal weight was 619 gram. We plan for injection natural micronized progesterone once weekly after discharge. Thank you. Now I will.
अगर इसको छोड़ दें, सर्जरी नहीं करें और बिलिरुबिन लेवल्स बढ़ते रहें, जॉन्डिस बढ़ती रहे, तो क्या इफेक्ट होगा?
सर
क्या प्रॉब्लम है मदर को, क्या प्रॉब्लम है फीटस को?
सर फीटस का सडन आईओडी होने के चांसेस बहुत ज़्यादा बढ़ जाते हैं.
क्यों?
सर बिकॉज जो बिलिरुबिन होता है वो प्लेसेंटा को क्रॉस करता है, जो कि बहुत ही इरिटेंट है, एंड विच विल व्हेन फीटस मतलब वो फीटस इनहेल मतलब कर लेगा, फिर वो
फीटस से पहले तो मदर पे हो ना.
यस सर.
मान लो लेवल्स बढ़ गए, 14 मिलीग्राम हो गए और ज़्यादा हो गए, 20 मिलीग्राम हो गए, क्या होगा? कोगुलेशन प्रोफाइल करती हो?
यस सर.
क्या 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 इफेक्ट होता है जॉन्डिस का? विटामिन के लेवल्स पे, पीटी, सीटी, सीआरटी.
एक्लेम्शिया हेल्प्स इन.
अरे एक्लेम्शिया को मारो गोली, पहले तो उस पे आओ ना, बिलिरुबिन पे.
बिलिरुबिन, यस सर.
डीआईसी में चली जाएगी पेशेंट, ठीक है ना. कोगुलेशन प्रोफाइल बिगड़ जाएगा पेशेंट का. दैट इज वाई इट इज वेरी रिस्की.
ओके सर.
प्रेगनेंसी में जॉन्डिस होना इसलिए बहुत ज़्यादा रिस्की है कि चांसेज ऑफ कोगुलेशन फेल्योर आर वेरी वेरी हाई.
ओके सर.
It is not the icterus, it is not the jaundice, not the discoloration. All right.
Okay, sir.
It is the DIC, which is coagulation profile, which goes disturbed. All right. You must know that.
Okay, sir.
Chalo.
Now I would like to call Dr. Anshul Vishnoi, sir, DM resident, 3rd year.
Good morning, everyone. Imagine being responsible for not just one, but two lives who are intertwined, delicate, and entirely responsible on our management. So, with this, I would like to start. I am Dr. Anshul Vishnoi, DM resident in organ transplant anesthesia under the guidance of Dr. Vijay Mathur, professor and head, and Dr. Kaushal Baghel, assistant professor in the Department of Anesthesia. So, we had challenges and consideration for both mother and the fetus. So, her airway, her respiratory functions, all were at stake. Her cardiovascular system has changed because of increased cardiac output, decrease in the systemic vascular resistance, increased aortocaval compression because of the gravid uterus.
pregnancy itself is a hypercoagulable state, and of course the physiological anemia of pregnancy. So for fetal, the uteroplacental perfusion is very important because we cannot compromise that. Hypotension and hypovolemia will directly cause the fetal hypoxia as well as fetal acidosis. Again, the anesthetic drugs would lead to the placental transfer, causing teratogenic effects on the neurological development of the child, which occurs till the 3rd trimester of the pregnancy, and the fetal monitoring. So we have to avoid and treat the preterm delivery and labor. So when this patient presented to us in the pre-anesthesia clinic, so her obstetric history was 23 weeks plus 4 days of gestation with no known comorbidities. She had one surgical history. She had one surgical history of open choledochal cyst removal and hepaticojejunostomy before her pregnancy, which went uneventful and had no other anesthesia complications. Currently, she was on multivitamins and iron support. So we made emphasis on the consents, which is very important during this surgery. So there was a potential for preterm labor as well as fetal distress or demise and neurocognitive disorders of the fetus after delivery. And of course, the high risk for anesthesia was always there. Now, the intraoperative management is very crucial in such patients because it requires meticulous involvement of both general anesthesia as well as regional anesthesia. So we proceeded with thoracic epidural at T8, T9 level. Now, the benefits of using thoracic epidural along with general anesthesia are it is superior pain control and has an opioid sparing effect, which in turn affect the fetus. Now, her respiratory compliance is improved in terms of improved pulmonary mechanics as well as diaphragmatic function in the intraoperative as well as in the postoperative period. Now, it also results in reduced surgical stress response, decreased requirement of inhalational and intravenous anesthetic agents, and reduced exposure of such drugs to the fetus. All in all, improved uteroplacental blood flow. Now, in the intraoperative period after the thoracic epidural, we proceeded with general anesthesia. Standard ASA rapid sequence induction and intubation was done with the reduced doses. Standard ASA monitoring was applied. Invasive BP monitoring in the radial artery catheterization was done for beat-to-beat monitoring. Bispectral index was applied to assess the depth of anesthesia because we are using the reduced doses in the pregnancy. Might lead to the awareness, which is also deleterious to the patient. And again, the cardiotocography in the pre and the post-operative period was done to assess the fetal well-being. Normothermia was achieved with forced air warmer blankets and IV fluid warmers. Normocapnia was achieved with continuous EtCO2 monitoring, and normovolemia with pulse pressure variation guided goal directed fluid therapy. All this is very important during the intraoperative period because if a patient leads to hypothermia, again decreases the uteroplacental blood flow. If there is no hypercarbia or hypocarbia, again it changes the uteroplacental blood flow and leading to fetal acidosis. Now, this is a glimpse of the monitoring that we did during the intraoperative period. As you can all see, the vitals are rock solid, and we did the BIS monitoring, which was between 40 to 60, which is adequate for the depth of anesthesia for surgical response, and PPV guided goal directed fluid therapy. Again, a glimpse of the anesthesia gas monitoring and the lung mechanics on the ventilator, which shows that all the parameters were within the normal limits and the surgery went uneventful. As we can see on the graph, all the vital parameters during the 190-minute procedure was fine. And in the post-operative period, the patient was extubated immediately after the surgery. The cardiotocography was normal, fetal heart rate was normal, baby was fine. And now the post-operative pain management is where it is most important for such patients because the scar is huge. The incision covers almost the 1/3 of the abdomen up to the xiphisternum, where in the post-operative period, patient might land up into pulmonary complications, which can lead to pain. Pain again causes the contraction of the uterus and might lead to fetal distress. So intermittent epidural top-up with ropivacaine 0.1% is sufficient, and SOS paracetamol for the pain cover. Thank you very much. I would like to invite Dr. Ajay Sharma sir, professor and head for
surgery, because once I always say to my patients, I know I do good surgery. I am confident of that, but it is only possible because of this team that I have. Strength of Dr. Avanish sir, Vijaya ma'am, and Kaushal being there. That gives me the support that I can do all these procedures. इसमें हमारा काम ज़्यादा नहीं था, हमारे को तो वही करना था जो सब में करते. I think it was their task that was more important. So I am thankful to them. Intraoperatively, we found a hepatogenostomy site stricture as we anticipated. There was a very small pinhole meatus, dilated duct proximal to it, so we could easily get that dilated duct proximal, and we did this with an interrupted hepatogenostomy. We often do continuous suture, but in this patient I did not want to take any compromise, so we did with the interrupted suture with a PDS 40, and this is the hepatic hilum we can see. This is the rulu in this patient, and as we have mentioned earlier, we do a air leak test that we push air into this, and so as to see if there is a leak into this will show as a bubbles at this point in time, which we have already published now. So this is a standard technique which we have established now. The difference between
just मेरे थॉट्स हैं जो मैं आपको शेयर करना चाहता हूँ. स्लाइड बताना पहले वाली. जैसे जो इंटरप्टेड सूचर्स यूज कर रहे हो ना, उसको छोड़ देते हो आप.
यस सर.
उसके बजाय अगर आप एक सर्जिकल जो लेयर आते हैं ना, सर्जी श्योर या जो आती है सर्जी सेल, वो आप लगा दो तो जो चांस ऑफ लीक होते हैं ना वो बिल्कुल मिनिमम.
सर वो दैट हैज बीन नाउ पब्लिश्ड एंड इट हैज बीन ट्राइड. आई एग्री दैट व्हाट यू आर थिंकिंग was correct, but now I think literature says
it will prevent the stricture also, and it will prevent the leak also. Maybe this is my thought.
Sir, I agree. What you are thinking is correct, but seeing to a rational scientifically, I would not go by this, because now scientifically this has not been recommended. This has been tried. We published our data on omental flap in pancreatic duodenectomy, but then subsequently there was a lot of criticism after 10 years after that. So I think that is, so best is to do an interrupted suture, and holding the suture, that is definitely good. We do it continuous also, we have good results. So this is the basic slide which I want to show, that you have this hepatogenostomy site which is now extending into the left duct. You see the hilum at the lower end. I think the pointer is not showing on the screen. What we see, this is the site of the anastomosis. So we extend it from this up to the left duct. That is the basic crux of the procedure. So this was the original anastomosis that you see in the common CPD, and we do an anastomosis lower down. So just to, since we are running short of time, I'll just take 2 more minutes to complete that. Post-operatively, the patient's course was uneventful. Patient had gone home. She was under the consultation with a local gynecologist. We asked for a report of LFT, since at the time of discharge, the LFT had improved. After 2 months of the surgery, her LFT was absolutely normal. She delivered a normal child, and
मैंने महात्मा गांधी हॉस्पिटल में डॉक्टर अजय शर्मा से अपना ट्रीटमेंट लिया और मेरी एक सर्जरी हुई इन प्रेगनेंसी. उस सर्जरी के बाद मतलब मेरी हेल्थ कंडीशन बिल्कुल ठीक हो गई है, एंड नॉर्मल डिलीवरी हुई मेरी और बेबी और मैं उसके बाद अभी तक बिल्कुल ठीक.
So I would say thanks, because of this institute we could do it. If it was at some other place, it was difficult. I would say thanks to my team of all members who could support to us, anesthetists, obstetricians, the management, and in sub के support के अलावा there is a CCR review committee. I would like to thank especially the CCR review committee, because all these questions were formulated by them, which we have discussed, because this is definitely a lot of things which come into the mind. Why not this? Why do you think against us? So we think against many of the things because we have a strong literature support by which we can say. So before saying thank you to everybody, there are 2 things which I would like to just